All right, good morning, good afternoon, everybody. I'm James Baker. I'm an emergency room physician and an ACLS instructor since the mid-90s. Welcome to this segment of ACLS preview videos. As usual, we're going to present some material from the ACLS, American Heart Association guidelines. The purpose of these video segments is to allow you to review the material, give you a preview of the material before you come to our ACLS class. That'll give you a heads up on the material and allow you to be a little bit more prepared to make class go that much more smoother for you. The material that we are using is from the American Heart Association, the last guidelines, 2010, American Heart Association guidelines. The material is straight out of this book, or the provider manual, which again is the 2010 latest guidelines from the American Heart Association. And as we always say at the beginning of these little video segments is these are guidelines that we are teaching, guidelines from the American Heart Association. If in your clinical practice you come across a situation that requires you to deviate from the guidelines, go ahead and do so if your clinical judgment tells you to deviate from the guidelines. These are primarily guidelines for the purpose of studying and preparing for our ACLS classes that we put on here at our medical center. So today's class will be the post-resuscitation care, post-cardiac arrest resuscitation care. And we will most likely, when you're in our class, give you the post-resuscitation scenario after we've resuscitated a patient, and we will make sure that you are instituting all of the usual measures that needs to be done to stabilize our patient after cardiac arrest and to make sure that they don't go back into cardiac arrest. Okay? So, we're going to begin. Here is our patient that we have been working on, that we've been resuscitating. It might be a VFib arrest or a VTAC without a pulse, or asystole or PEA, whatever the case may be. We've been doing CPR, our 5 cycles, 2 minutes. We've been shocking, we've been giving medications, and then at some point during the resuscitation, we look at our monitor and something new comes into view. And that's a catchphrase that we use in our classes here. When something new comes into view, be sure to check the pulse. Okay, so here we are. We've gone from VFib or asystole to something new coming into view. This is a normal sinus rhythm at a rate of 70. So the catchphrase, when something new comes into view, be sure to check the pulse. So on our mannequin here, our pulse that we're going to be checking is obviously the carotid pulse. So we're going to be checking his carotid pulse, and the instructor can control the pulse, and I don't know if you can see that, but you can see actually a carotid pulse. And in our classes, we make you actually go through the motions to feel for a pulse. So, if there is a pulse, then you're not through until you check the BP2, blood pressure 2. So, we want you to say, I feel a pulse, what is the blood pressure? And we will tell you what the blood pressure is. Typically, in these post-resuscitation cases, we're going to give you a blood pressure less than 90. So we're going to tell you blood pressure is 80/50. Okay? So you're going to need to know exactly what to do to end these cases with a systolic blood pressure of 90 or higher. So we've resuscitated the patient. We have a pulse. We have a blood pressure. Another clue that you might see during resuscitation and post-resuscitation is a change in that PET-CO number, that PET CO2 number, or that waveform capnography number. And just to review, if our patient that we've been working on during doing a resuscitation, if he is intubated and he has an advanced airway ET tube in place, we've put in line our PET-CO waveform capnography unit. So it goes right on the end of the ET tube. Our bag valve mask is up here. Our little port goes to the little connector, which is in our machine, and we have been measuring waveform capnography expired CO2 values. Remember the two numbers with that. If the PET-CO number, PET CO2 number is less than 10, then you've got to improve the quality of CPR to get that number to 10 or higher. during resuscitation, if that PETCO number, waveform capnography number, jumps up to 35 to 40, that's an indicator that you've got a return of spontaneous circulation as well. So that's one indicator, plus a change in rhythm, confirmed by pulse and blood pressure check. You've resuscitated this patient. So as we look at our algorithm for the immediate post-resuscitation cardiac arrest care, we've clarified we have Rossi, return of spontaneous circulation. So we're going to check our ABCs, make sure our oxygenation and ventilation is intact, make sure our O2 sat is reading, and we're at 94% or higher. We will assume we've already got an advanced airway in place with waveform capnography in place, and the instructions are do not hyperventilate. Do not hyperventilate, do not do excessive ventilations, because you're going to put too much air into the gut, into the stomach, which can possibly cause regurgitation, aspiration, and higher pressures in the chest, which can decrease blood flow to the heart and to the brain. So do not hyperventilate. In fact, it will tell us here, ventilation and oxygenation. Avoid excessive ventilations. You're going to do 10 to 12 breaths per minute with an advanced airway in place. You're going to be monitoring that PETCO number and targeting it to a 35 to 40 reading. A, B, C, you're going to check your circulation and your blood pressure. If your blood pressure is less than 90, that's the key one. We want to end these cases with a systolic of 90 or higher. If you're less than 90, the book will tell you to give an IV fluid bolus, or IO if you don't have an IV line in place, an IV fluid bolus of 1 to 2 liters of normal saline. Remember that number, 1 to 2 liters of normal saline fluid bolus to get that blood pressure above 90. If that doesn't work, you might have to start a vasopressor infusion. Okay, so our vasopressors, if we come back to the screen on the right, we usually, in our practice, we usually start with dopamine, and the dose is 5 to 10 mics per kilo per minute. And I'll give you a warning, make sure you know this dose, and remember, this dose is a little different than the dose we use for symptomatic bradycardia algorithm. Okay? So for post-resuscitation hypotension, 5 to 10 mics per kilo per minute. You can start that infusion. If that doesn't work, or you feel the need to change to a different pressor, then we go to epinephrine. Epinephrine dose is 0.1 to 0.5 mics per kilo per minute. Again, a warning. Remember this dose. This dose is a little different than the epi-infusion dose for symptomatic bradycardia. Okay? And then the book will give you a third option of using norepinephrine. We don't use this too often in our classes. We focus on the first two, but there is norepinephrine you can try at 0.1 to 0.5 mics per kilo per minute as well. Okay? So once we get those started, we've bolused them or we've given the vasopressor, our blood pressure hopefully is above 90. We need to order a post-resuscitation EKG, chest x-ray, and lab work, blood gas, cardiac enzymes, anything and everything you can think of, just order it at this point in our post-resuscitation phase. Now, the book will also talk about if our patient was in VFib or VTAC or one of those other arrhythmias, we need to put this patient on an anti-rhythmic infusion drip. And if we go back to our monitor here, our cardiac monitor, sometimes we will show our post-resuscitation rhythm and we'll clue you in on some ectopy that's happening. So you see some PVC starting to come into play here. And that will be a clue to remind you that this post-resuscitation patient that was in VFib or VTAC, they probably need to be on an anti-rhythmic infusion drip. Typically, we will select the one that we used last during the cardiac arrest. So if this was VFib and we gave amiodarone, then we're going to put this patient on an amiodarone infusion maintenance drip to make sure they don't go back into VFib or VTAC. The dose for the amiodarone infusion drip is typically 1 milligram a minute for the next 6 hours, and then you half that to 0.5 milligrams a minute for the rest of the day, for the rest of the 24-hour duration. So remember, your post-resuscitation antiarrhythmic infusion drip needs to be started on these cases. Otherwise, we'll make our patient go back into VFib because you haven't stabilized them adequately. So now back to our algorithm chart, our poster. We've got their blood pressure stabilized. We've got them on antiarrhythmic infusion drip. We've done a quick rundown of our A, B, C, Ds, make sure everything is stabilized. We're going to see if our patient is waking up. Do they wake up and follow commands? So we're going to shake and shout our patient. We're going to say, hey, wake up, open your eyes. Can you hear me, Mr. Jones? Can you hear me? If they do not wake up and if they do not follow commands, that takes you to this branching point in the algorithm where we need to consider inducing hypothermia. And hypothermia is cooling our patient down. So studies have shown, research has shown, that patients have a better long-term neurologic outcome if they are cooled down. If we cool them down, the metabolism will slow in the body, the brain cells will use less oxygen, there'll be less oxygen demand, the cell membranes of the brain will remain stronger and intact, will therefore prevent toxic chemicals and other toxins, superoxide radicals and so forth from getting into the cell and causing cell damage. So it's protective. Therapeutic hypothermia is also called protective hypothermia because it will slow metabolism and protect the brain. Now we're going to cool the patient down to a temperature of 32 to 34 degrees Celsius, okay, which equates to about 91 degrees Fahrenheit. And the way we cool these patients down is a number of ways. We can pack them in ice. We can start 4 degrees of chilled normal saline through the IV lines, or we can use an external cooling blanket. We have one that's called the Arctic Sun that we wraps up the patient torso and thighs, and it's a machine that cools our patient down to that 32 to 34 degrees Celsius for therapeutic hypothermia. Now, we mentioned post-resuscitation. If our patient also has is recovered, we're going to order, I said, post-resuscitation EKG, chest x-ray, labs, everything else. Along with that post-resuscitation EKG, we're going to be looking for ST elevations, which can indicate our patient has a STEMI, or an ST elevation MI. If they do, if we see on that EKG 2 to 3 leads, contiguous leads that show ST elevations, which are indicative of an acute MI, we've got to send this patient to cath lab to do coronary reperfusion. Okay? There's 2 ways to reperfuse the coronaries. One is with fibrinolytic therapy. The other is PCI, percutaneous coronary intervention through the cath lab. That way is the preferred method. PCI treatment is the preferred method. And PCI therapy combined with hypothermia can be done together. So you can really save the patient's life, save their heart, and save their brain if you act fast and combine those 2 maneuvers, those 2 measures. Okay? And I think that pretty much covers the main points for post-resuscitation care in ROSI, in stabilizing our patient. Just a reminder, we want to make sure we do a quick run through of the ABCs, make sure airway is intact and secure. And I will give you another little point. When your ET tube, your advanced airway is in place, make sure you secure it with a commercially available ET tube holder. Try not to use those trach ties or those tapes that go around the neck, because sometimes those tapes can be too tight. And if they're too tight, they can restrict blood flow coming from the brain, leading to brain swelling and edema. We don't want that to happen. We're looking to save the brain. So use an adjustable ET tube holder like this one, where the ET tube goes right through the device, just like that. and you can tape it in place. And this goes underneath the head and neck, just like that, and you secure it in place. Just like that. Okay? So ET tube holder in place, securing the airway. Do not hyperventilate. Aim your ventilations 8 to 10 breaths per minute. Aim your Petco number to 35 to 40. Make sure your vitals are all taken care of and stabilized. Make sure your IVs are intact and in place and working. Make sure you get post-resuscitation EKG, chest x-ray, labs, ABG, enzymes, everything you can think of. And with that, once you've stabilized the patient and you've considered all the possible reversible causes that we've talked about in the other videos, the 5 H's, the 5 T's, make sure there's nothing obvious that you are overlooking that can be readily corrected, whether it be an acute MI, whether it be a hypo or hyperkalemia problem, an acidosis problem, a hypoxia or hypovolemia problem. Make sure you address those. And once you've done that, you can admit your patient to the ICU and consider it a save. Okay? All right, I think that covers all the main points for post-resuscitation, return of spontaneous circulation care. Thanks for watching. Make sure you watch the other video segments in this series so that you come to ACLS class prepared and ready to learn and ready to put your knowledge to practical use. Thanks for watching.